A very good afternoon to everyone, all the attendees and the speakers who have joined for this webinar. This is our another episode that is with the collaboration with Cipla Diagnostics with the theme of amplification, reimagining diagnostics with Cipla Diagnostics. The topic of this webinar is emergence of a variant of concern with immune escape and increased transmissibility. The speakers for this session who will be talking about this topic is, first up, we have Professor Dr. Ashok Rattan. Sir is a Professor of Microbiology and Advisor, Quality Research and Development at Pathkind Labs. We also have Dr. Sanjay Arora. Sir is Managing Director and Founder at Suburban Diagnostics, India. And we have Dr. Anusha Rohit. I'm a Senior Consultant and Head of Microbiology and Chair Infection Control at the Madras Medical Mission Hospital, Chennai. Dr. Anusha will also be leading this conversation and posing up the Q&As. We also have Dr. Rohit from Medical Affairs team at Cipla Diagnostics, who will just take it over from here. So, Dr. Rohit, over to you. Thank you.
Thank you so much, Khushbu. Myself, Dr. Rohit Malabde from Medical Team Cipla. So I welcome all the faculty members for the meeting. The topic is the chances of re-emergence of vaccine-resistant transmissive variant COVID-19. And I welcome both the speakers, Professor Ashok Rattan and Dr. Sanjay Arora, and the moderator of today's meeting, Dr. Anusha Rohit, for the meeting. And would like to hand over session to Dr. Anusha Rohit. Over to you, madam.
Thank you so much, Cipla Diagnostics, and the really esteemed chair people who are going to be at today's meet. At the outset, it is indeed an honor to be part of such a meet because we are talking about a very, very interesting variant of COVID-19 that has recently come out along with the other details. What we've heard is that this particular variant spreads better through newsrooms than through person-to-person contact. And in continuation with that, let's learn more about what is the true concept of this whole, the whole concept of variants, how they are formed, what about this? We're still 2 years only into the COVID-19 pandemic, and we still have lots to learn, lots to describe, and lots to improve as well. So without further ado, thank you, Cipla, again for the opportunity, and I'm going over to share my screen so I can introduce, a brief on the two esteemed panelists at today's meeting. It's really indeed an honor to introduce to you all Professor Ashok Rattan. He is a medical microbiologist by profession, and he has been conferred the APJ Abdul Kalam Award for Lifetime Contribution in Medical Sciences in 2018. He has also won various other orational awards for his contribution in tuberculosis research. He has held important positions like in AIIMS Delhi or in Jain Medical College, Mahatma Gandhi, Jaipur, and the UAE also. Sorry, I didn't realize I wasn't on the mode. Right. And following that, he has been associated with various labs. He has published over 100 research publications in peer-reviewed international and national journals, and guided over 40 students through their MD, MSc, and PhD. He has been named in 30 international patents, which essentially shows the quality of work that he has actually done. He's also the author of NBT-sponsored book published by Churchill Livingston, that is the Antimicrobials in Lab Medicine. He's contributed more than a dozen chapters in various textbooks as well. Thank you, sir, for joining us. And next, I go on to have the, I have the honor of introducing Dr. Sanjay Arora, again, the founder and managing director of Suburban Diagnostics India Private Limited since 1994. So he has hordes of experience with managing labs and testing activities across Maharashtra, Goa, MP, and Chhattisgarh. He's serving over 9,000 patients daily with a team of 1,200 people. They are NABL and CAP accredited, and they provide comprehensive diagnostic services, including pathology, radiology, cardiology, and preventive medicine. So with that brief introduction into the speakers, I would like to hand over the, for a brief overview of the topic to Professor Dr. Ashok Rattan.
Thank you, ma'am. We would today discuss about emergence of a variant of concern with immune escape and increased transmissibility. As you all know, it was on 31st December 2019 that WHO was informed by the Chinese authority that there was an outbreak of pneumonia caused by a novel coronavirus from Wuhan. By the 10th of January 2020, one full sequence of this RNA virus was made available in the public domain, and the next day 5 more sequences were available. Based on the sequences seen, CDC Atlanta started working on an RT-PCR for this RNA virus based on N gene, while the Koch Institute in Berlin focused on the E gene, followed by the RD-RP gene for making the diagnosis. Right from the beginning, test, trace, and isolate was the watchword for the first time, diagnostics came into center stage. For RT-PCR, the sample, which was nasopharyngeal swab or nasal swab or throat swab, and surprisingly not saliva, which would have made life easier, was selected. And then after extraction of RNA, a reverse transcriptase was done, and then real-time PCR was analyzed, and then the results will be. You would notice that in PCR, there would always be an increase in doubling of the sample till a threshold is crossed, and this will be known as CT values. So this CT values were very important. ICMR ramped up the diagnostic work that in January, when first information came about the coronavirus, there was only one lab, NIV Pune, which had the reagents to be able to do RT-PCR. But by September 2020, about 2,200 labs were NABL accredited as well as ICMR approved. At this moment, about 3,020 labs can do the work. Along with that, there were a lot of activity from the manufacturing side, where they made not only molecular tests, but also antigen detection and serology, as well as the regulators. Regulators normally, who are very conservative, showed extraordinary cooperation and approved many of the tests to be used as emergency authorization. The molecular test could be divided into RT-PCR, transcription-mediated amplification, RT-LAMP or CRISPR, and the genes on which they focused, depending upon whether they wanted to do manual method, in which they focused on open reading frame 1A or open reading frame 1AB, RD-RP, E or N or S gene. Again, as the load increased, automated systems also became available, focusing on the same kind of genes. We had started doing RT-PCR and selected Thermo Fisher multiplex PCR for the test. The advantage was that it used 3 specific genes for the virus, along with the housekeeping gene, and they would be, and these were from sites which were away from the mutation. It was also suggested by them that at least two virus-specific genes must be present before the virus could be reported as positive. And it was then subsequently it was noticed that if a S gene became silent while the virus was positive, then it was initially in October 2020, it was the Nelly mutant, which was N501Y, which also had a deletion mutation at 6970 position, which was the binding site for the forward primer of the S gene. And the new variant that we are now reporting, the 𝐿, as some persons feel that it's better to call that as 𝐿 as Omicron. And Omicron also had the same mutation as the Nelly variant or the alpha variant. Now, for a report to be reported, MS gene must be amplified. Then this will come as a negative report. It would mean that the RNA could be extracted and MS2 has been amplified. On the other hand, if only one gene, for example, ORF1AB, was amplified along with MS2 gene, then it would be an inconclusive report. For a report to be reported positive initially, the N gene, the ORF1AB gene, and S gene would be positive. All three of them, or at least two of them, would be positive for the report to be reported as positive for SARS-CoV-2. And in case there was no amplification, that would mean that it's an invalid run and the test has to be repeated. Along with this time, we came to know from Bullard, where not only was he doing sampling and doing RT-PCR, but also culturing. And they noticed that it was only in the first 8 days could the virus be isolated in culture. And he had proposed that if the CT value was less than 24, then that means the sample is infectious and the sample contains cultivable virus. While if it is higher than 24, then it's only a remnant of RNA which we are amplifying, and the patient need not be isolated. This helped influence the discharge policies of all the authorities. As I mentioned that in October 2020, then we had S gene silencing in the UK, where they noticed that the ORF gene and the N gene was being reported, but there was no S gene in that Nelly mutant. And this was silencing of positive samples, which had either Nelly or now Omicron, which has a mutation a deletion mutation at 6970 site of the spike protein, which is the binding site for the S primer. It was in March 2020 that Nature published a paper about making sense of coronavirus mutations. They had suggested that since it's an RNA virus and its proofreading ability is not very strong, unlike the DNA viruses, the whole length of 30,000 base pair, there would be mutations. But most of the mutations, if they are not effective, then there would be mutations or variations of no consequence. It was only when mutations occurred which changed the character of the virus, would you say that there's mutations or variations of interest? If it increased the transmissibility, if it increased the virulence, or if it increased the immune escape, then it will be a variation of concern. The first mutation which changed the dynamic was the D614G mutation. The primary aim of protection was that either natural or after vaccination, antibodies would be formed to the spike protein, which will prevent the binding of the spike protein to the ACE2 receptors on human cells, so that initiation of infection would not occur. Any mutation in this would change the situation. And the D614G mutation in the spike protein indicated that though this was not at the site of attachment, but by opening up the spike protein, the affinity for ACE2 receptor became increased. And subsequently, they noticed that not only the mutation was present in 614 position, but Nelly was N501Y, then EEC was 484K, and subsequently we had the Delta variation, which caused havoc in May and June this year. So as you notice that in 2020, it was the D614G which replaced the existing Wuhan strain. And subsequently to that, we had the Delta variant, which has become the dominant variant all over the world. Now we come across from, initially it came from South America, but South Africa, but it appears that the Omicron variant was available in Holland and in other places even before that. And as you notice that it is much more transmissible than beta variant, the Delta variant, and Omicron is highly infectious. Some would suggest 7 to 8 times of Delta. Though it was first reported to WHO by South Africa, but it was seen that Botswana had the first isolate by 11th November. Netherlands had cases even before that, but not reported to WHO. And one case from South Africa landed up in Hong Kong, where he was isolated, and while he was in quarantine, a second case was also reported from Hong Kong, which was just across the hallway. Omicron had more than 50 mutations. 32 mutations are in the spike gene itself. This is a high variety of mutations in one isolated cell, and is not linked to Delta variant. The 32 mutations is the S gene have been mapped out. The red one means that it is bad. Purple is that there are new mutations, and you see that there are mutations near the monoclonal antibody binding sites. Yellow would mean that we don't know what they mean yet. Blue, we have never seen these changes before. They may mean something or may mean nothing. And green is, this is a mutation that has been present in all the variants since early 2020. So what we are worried about is increased transmissibility. Yes, this is 7 to 8 times more transmissible than the variants earlier. Then there is escape from escape from neutralization from antibodies. And whether there is increased severity or not, the primary indications are that it is a milder infection and it has not pushed many persons to ICUs or to hospitals. This case I've already mentioned about in Hong Kong, first case and then the second case. And it is not only in Hong Kong, but now at least 24 countries, including India. India yesterday reported from Bangalore 2 cases, and subsequently you'll find that about 24 countries are now reporting Omicron. So the aim of shutting off the airports, etc., may be a bit too late. And Omicron is spreading much faster than any of them. But if you look at the clinical features, there's extreme tiredness, sore throat, muscle pain, and dry cough, with some rise of body temperature. That would mean that the clinical features are different than that of Delta or the other viruses. There is no loss of taste or smell, no decrease in oxygen saturation. All patients have recovered without hospitalization. No ICU admission or death have been reported as yet. If the virus only causes mild infection, and I guess the jury is still out on this, but if it only causes mild infection, then it will act as natural vaccination of the entire population and may meet the end of the pandemic. However, if we are not yet vaccinated, then it is suggested that since vaccination offers much more protection, we should complete our vaccination. And if we have had 2 doses and more than 6 months have passed, we should then, and we have comorbidities, then we must take a booster dose. GSK has today reported that their monoclonal antibodies will work against Omicron, and there are other cocktail of monoclonal antibodies available which will be able to neutralize many of the viruses. I think that's all that I had to present at the moment. We need to get more information as the time goes. Thank you.
That was really interesting. It caught us all like completely. We were hooked on to every word that you were saying. So it was very nice. Thank you, sir. Dr. Sanjay Arora, would you like to say a few words before we start off with the discussion, just on your experience of the pandemic so far as a testing lab, etc.?
I think Dr. Rattan has summarized it so beautifully, left very little for me to say. I think the last line of one of the slides was very important, that if this is actually a mild infection, it could actually be a surrogate vaccine, which would actually be driving towards the end of the pandemic. I read an article recently from the head of the Medical Association in South Africa, the lady who actually first reported this case. And she mentioned exactly the same thing, that they're seeing increased hospitalization merely because of higher numbers, not because of higher severity. And she also believes that the infection is much milder, and if this variant actually overtakes the Delta variant, and it's a much milder illness, then this could actually be a blessing in disguise for us.
Thank you, sir. Thank you so much. So let's start from the beginning, and we can discuss as we go ahead. I'm coming back to you, Professor Rattan. I wanted to know your thoughts on the lab leak theory. I know there's so much you've spoken about it, and the drastic and the gain of function and all of those things. So what are your thoughts on the lab leak theory?
Lab leak for the original Wuhan virus?
Yes, yes.
I think there is some evidence towards it. But I think scientists should not speculate. They should actually get more data. And I'm also aware that WHO with the current organization is not going to permit that. If, as you know, that Omicron should have been actually new virus. If you look at the Greek alphabet that it was labeled as, then new was the next, and then there would be Z.
Z.
Z. So Z was next, and they skipped these two just so that nobody takes objection. Now, that is not how science is done. Science is done by following the rules. You make your rules and then you don't follow them. That leaves me with a bad taste in the mouth.
I so agree. That's, putting it very bluntly, I think it's important that science is above politics, more than anything else during a pandemic. What are your thoughts, Dr. Arora?
Right. So I completely agree with what both of you are saying, but I think there is a lot of speculation going around that is it a man-made, is it, intentional warfare, is it, biological warfare, is it politics, as you mentioned. I think, but there is a lot of maybe surrogate evidence to suggest that there is a lab leak. And there's a lot of articles, a lot of information on that. This is definitely not the last. It's not been the first and definitely not the last case of a lab leak. So I think I would subscribe to your question that yes, I think just to put people at rest, I would err towards thinking that yes, this is more a lab leak than intentional biological warfare. And I think this is a misstep by one of the labs in Wuhan, perhaps, which has, resulted in where we are today. I think it just sort of allows us to be more on our guard that, all of us who are working in labs, especially the research labs, the responsibility that we have towards, society and mankind.
Right. And, at this juncture, I would like to take the opportunity to say when, Dr. Rattan's also a teacher and you are associated with so many labs and I'm an assessor with NABL myself, the concept of risk assessment, the concept of the care to be taken, especially in research labs, is very less because our syllabus doesn't really push for a lot of data on syllabus, which is focused on a risk assessment and that. So if even if we're going to give some percentage of doubt, I think, I would use this platform to shout out to to people to say that let's learn from this pandemic and let's go ahead. Absolutely. Going ahead with, what we were discussing. Professor Rattan, now, as you said, this Omicron variant, because it's in the news, we're talking about it, but don't you think we should be sequencing a lot more in this country and probably every country? US is right now reporting over 1 lakh cases. Countries like UK are reporting over 45,000 cases. India is reporting a decent number right now, but don't you think the INSAGOG and the world GISAID should have a lot more sequences and data present there? What would be your thoughts? I'll ask it one after the other so that we have both of your interesting views on it. But because yes, sequencing costs. So how do we set the balance? What are your thoughts, Dr. Rattan?
See, one has been, and that I think is the price which has been driving our diagnostics. As a consequence, though we started off with TAGPath, which would have alerted us had we continued with TAGPath. But TAGPath was the time when we were charging 2,400 for that. Subsequently, now the cost is 450 or so. So as a consequence, only a cheaper version of the test were being used. I also felt that when in that medical college in Karnataka, about 250 persons became positive.
Yes,
that should have alerted us that something is there. And if we sequence that, then you'll find that this was Omicron. We also have noticed that there's no data sharing. We had, when Delta came, we had persons, we had staff members who have been vaccinated, who had also suffered in 2020 and had very high titers. And still, when we isolated an RT-PCR case and sent that, we still haven't got back whether it is Delta or not. So somehow we keep talking about collaboration and sharing data, but no data seems to be flowing from one side to the other. It's also, I noticed that everybody is talking about next generation sequencing, But if you're going to sequence only S gene, then there are multiplex PCR also which can help you do the same.
Exactly.
So it is just being aware, not being caught napping every time. And I think this time again, as you'll notice that the second person in Bangalore is a doctor working in the government setup, has no exposure to anybody, who has been abroad and is Omicron positive. So my guess would be that Omicron has been in India for some time now.
I agree.
We would then rediscover it.
But we should have known earlier. I mean, we can't be just redoing the same mistake again and again. What do you think, Dr. Arora?
So I think, so maybe I'll step back a little, and I, again, completely agree with what Professor is saying. To give credit where it's due first to ICMR, I think in, increasing capacity of testing in PCR, I think they've done a phenomenal job in that. So I think credit to both ICMR and NABL in, spreading the accessibility of testing rapidly. I definitely believe that sequencing or multiplex PCR is a missed opportunity because I feel that more than us knowing about it, it's more about providing this data to vaccine manufacturers so that they can actually tweak the vaccine proactively, as Sir just said, rather than us being reactive about it. I think UK has a mandate of, if I'm not mistaken, 5% of their positive samples are sequenced. We have started sharing our positive samples with a reference lab in Mumbai, maybe about 50 to 100 samples a month. And as Sir said, we are still awaiting inputs on what's been the outcome of those analysis that has been done. But I think that at this point of time, if collaboration could increase the number of sequencing, and this information, this data sharing could be given to vaccine manufacturers, and we have two very large manufacturers in our own backyard, I think the outcome will be tremendous. Now, if there is a recommendation by WHO, I think US has already started giving a third dose, so-called booster dose. I defer to call it the third dose. But if that information is available, on we are talking about immune escape, or increase transmissibility or effectiveness of the vaccine, I think all that can be addressed if this sequencing material, the data can be given to the vaccine manufacturers in time for them to tweak, the third dose, which will be more effective against the mutants. I think that is a huge opportunity which we should be pushing for more aggressively.
I completely agree. Many times it is just, about how well we are keeping our eyes and ears open when we are in diagnostics also. Like, for example, I'm a routine diagnostic lab associated with a hospital. But around September last year, we saw a lot of e-genes not being, so I use the TrueNat. Of course, I'm, keeping it out here. I use closed systems because we are a small hospital. We cannot afford to have space with 3-room facilities. So, we've had to stick to closed systems. So we were seeing quite a few of them which were e-gene negative, but N-gene positive, or E-gene negative, but ORF positive or RDRP positive. And that is when actually we went through the sequences of GISAID and we put up our paper where we found that many isolates from Orissa, etc., had deletions in the E-gene. So sometimes I think multiple genes, picking them up is important. And like the WHO is now suggesting about diagnostics on the Omicron, they're talking about using S gene as part of the target, so that if it is not, you still have a kind of a surrogate marker. What are your thoughts, Dr. Rattan? Would you think that this would be a strategy? Because especially now that we've increased capacity for testing so well across the country, and that I am very proud of. Back in 2019, if everybody had told me before the pandemic struck, look, India is going to be doing so much RT-PCRs, I would have really, thought it was a foolish thought. But now it's very, very, yes, yeoman service done by ICMR and NABL. And I think we are, going towards having this across the country. So now, do you think, changing the targets, could we improve our diagnostics? What are your thoughts, Dr. Rattan?
See, up till now, the focus has been on getting the price down rather than making sure that the results are reliable.
Right.
And I guess we've had many instances where the reports of Indian labs and all labs which give out report are NABL and ICMR approved labs. The reports, when they go out, they have been contradicted. Even in the first Omicron case, the South African one, he came negative first, then his sample was taken, and then he'd gone to Dubai after getting a negative report here. So I think we have to focus on the quality, and the quality of the report would indicate that choosing one or two genes in a virus which is mutating at a very regular and a very regular pace would lead to false negatives. S gene silencing would have given us a clue had we continued to use the kit, the TagPath kit. But I was told that RT-PCR, which Apagi has made, would be able to make a positive diagnosis even if in case of Omicron. So it's naturally, instead of negative deletions could be always a help, but positive identification is always better. But I guess time has come now to pay more attention to participation in ICWAS and making sure that our results are right. And I've always doubted whatever the designation of reference labs, if they cannot demonstrate their job must be clearly defined. And then if they do not help us smaller private labs, then they are not fulfilling the mandate of being a reference lab.
Right. I completely agree, because many times we are using multiple genes because we have 3 platforms in our hospital, all closed systems, but 3 different platforms, and each one has a different target. But it's a lot of money, and it's difficult to convince a patient, because they say, oh, I'd get it at this much rate when I go outside. Why are you charging so much? And they don't understand the cost that goes in. What are is your experience the same, Dr. Arora?
So I think there's been so much of learning over the last 18 or 19 months on the evolution of testing platforms and testing kits. I think we've all gone through that. And one of the slides which Professor had shared earlier clearly demonstrated how many kits there are and what kind of target genes they have. And unfortunately, I think commercials take precedence over quality sometimes. And however, I think a minimum of 2 genes, confirmatory genes for the SARS-CoV-2 virus, I think that's the minimum that every lab should take, that they should have at least 2 confirmatory genes. And I think while TagPath is definitely there as a kit which picks up 3 genes, including the S gene, I think between the ORF, the RDRP, the N gene, at least 2 out of these 3, if the kits use, I think it's good. What we have decided now is that every positive case, we will cross-check with the TagPath kit to see if there is a S gene dropout. So we will continue using the kits that we have, but every positive we will cross-check with the TagPath. And if there is a dropout of the S gene, immediately we will try and notify the authorities for that. So at least those cases can be acted upon with more priority.
Right. Now, moving on to the fact of, yes, you have variants of concern and variants of, where you're not really sure about what the evidence is. Now, Omicron has been classified as a variant of concern, but we don't have enough data yet, at least, on the transmission or the severity. Severity, yes, there is some amount of data, but transmission and the recovery and the breakthrough, what are your thoughts on that? First, I will give the option to Dr. Rattan, and Dr. Arora, you can take it on later. Dr. Rattan, what do you feel?
I think the initial graph itself indicated that while it took 50, 60 days for Delta to come up to, say, 60% or so, in a few days itself, Omicron has replaced Delta and is from, say, a few handful of cases on 24th, by the 1st of December, they have come into thousands. So it would indicate that Omicron is highly infectious. It is also indicating that there's immune escape to a certain extent. But if it is mild, which then doesn't tally up with what we understand, if it remains to be mild, then I think it's blessing in disguise. But if it is severe, then of course we are into big trouble. So I think we need to be on our guard. And so we should also keep on practicing COVID appropriate behavior and finish our vaccinations or have a top up of the vaccination as soon as possible before we land into trouble.
Right. What about Dr. Arora? What do you think about?
So I think the one big difference between when the Delta variant became predominant and now is the fact that there has been a significant uptake in vaccinations. I think when the Delta variant came out in late March, early April, and then May, I think vaccinations were still, picking up. And perhaps that is why I think the Delta variant was far more lethal. And also, I think the preparedness of the health authorities was perhaps not as anticipated. However, today, I think with a large number of population having received at least one, if not two vaccines, I think that is definitely going to play a beneficial role in the outcome, even if people get infected with Omicron or Omicron. But like I said, I think it's still early days. We don't know. We know that there is increased transmissibility or infectiveness, but severity, perhaps, I think the vaccines will definitely, will save, the negative impact of, severe disease. We still don't know whether, senior citizens, immunocompromised people, people, who are on maybe transplants, what would be the impact on them. So I think there's still, the jury is out there. But I think the difference between Delta and Omicron is that I think vaccination has played a big difference and will continue to, play that protective role, which will, I think, blunt the impact of the Omicron to some extent.
Okay, nice. Again, now something very interesting is that we've, when we started off vaccinating healthcare workers in our hospital, I'm talking personally about the experience that I've had with our healthcare workers. Out of 1,500 of our staff, hardly 100 people, actually 100 to 150 took the vaccine. Then came the Delta. Overnight, everybody got so scared that within the next 1.5 months, we had completed 1,350 employees with their vaccination. We still had a few people who were denying to take the vaccine, but nonetheless. Now, what we did was we looked at their neutralizing antibody. Of course, at the outset, I want to put it very clearly here that we have no clue about the memory cells. We know that viruses work on memory cells and the T cell immunity plays a greater role than neutralizing antibodies, but we have no way to test that. So considering that, neutralizing antibodies seem the next best option. And what we've noticed is that our staff, healthcare workers who took the vaccine, initially they had, good antibody titers, whether it was Covaxin or Covishield, they had the option to take both. And then we checked it at the end of 1 month after the second dose, 1 month after the third dose. And then we told them 6 months later, please come back and give us an antibody titer. And we did it free of cost just to get them to feel good about it. And we are noticing that quite a few of them have dropped in their antibody titers. Now, considering what little we know about neutralizing antibodies and all of that, and the fact that Covishield essentially got a better neutralizing antibody quantity, especially reason being it is working on the spike protein, and the neutralizing antibody is where the spike protein acts on. So considering all of these, what are your thoughts on vaccination and breakthrough infections, and what is the need for third dose bar booster bar magical shot bar whatever? Do we really go ahead and take that? Dr. Arora, first you could take that, and then I will talk to Dr. Ashok Rattan on his thoughts about this.
So I think just to advocate being pro-vaccination, I think my team, in fact, our lab director, was one of the first people on 16th of January this year to be vaccinated. I took it 1 week later. I took my second dose sometime in March this year. It's been a little, maybe a couple of months since I checked my antibody status. I had developed antibodies maybe about 1500 plus, but it had come down to about 200 about 2 months ago. I have not checked it since then. My experience has been that almost everyone who has taken the vaccine develops antibodies. And we have seen almost in all of them, antibody response lasts for at least 6 months, if not more. And then it starts sort of deteriorating. So we are coming to almost 9 to 10 months since people have taken their second shot. And that's where the concern is. Then there needs to perhaps be a look on, and I think our authorities are currently in discussion on the third shot. And like I mentioned earlier, if data on mutations is given to vaccine manufacturers, they'll be able to tweak, the third shot to be more effective against the variants or the mutations. My other experience has been that I have seen fair examples of breakthrough infections. We've seen quite a few in our own team, in the medical fraternity, in family, and it's very variable. We have seen some breakthrough infections which are extremely, fatal, and some breakthrough infections which are insignificant. So it's very difficult to predict why and how a breakthrough infection is more aggressive in someone and less in someone. And, someone who's got no comorbidities succumbed to it, and someone who had comorbidities had a very mild infection. So it's counterintuitive. However, reinfection in someone who had tested positive, the numbers are far less. So I think probably a natural infection provides, in my opinion, maybe a better quality of antibody response and protection than perhaps vaccination does. Although, the data or the science says exactly the opposite, that vaccination, is far more effective than a natural infection. But my experience personally has been different. And I've seen people who were infected in the first wave in May, June last year, did not get an infection at all. And, they were sort of not taking all the best precautions. But people who took 2 doses of the vaccine, many of them, had breakthrough infections. But would love to hear Professor Ashok's, his response on this, because I'm maybe challenging what the data suggests, but that's been my personal experience on ground.
Go on, Dr. Rattan, go on.
Hello.
Yes, sir, go ahead, please. I think perhaps your video has frozen, but we can still hear you. Maybe internet bandwidth challenge, yeah.
Probably.
So maybe you could switch the video off, that might help. What's been your experience?
So literally about the same thing, but science itself says that a natural infection would produce better immune response. So I would tend to agree with what you're saying in terms of the immune response that comes. Maybe the natural infection along with a vaccination acts as a proper booster than probably even 3 doses. But what is strange is that, we have natural we have natural examples in countries like Israel, which have restricted to 1 or 2 vaccines. If you look at the data from Israel versus that of UK, you will see that Israel has more of Pfizer, less of the AstraZeneca, whereas UK has probably a mix of the two and in equal proportions. And the mRNA vaccines have dominated the North America. So
Right.
I think we need to have a lot more data coming on. Okay, Professor Rattan is here. Please take it on.
So you're on mute.
You're muted.
There was a paper from Yale University which addressed the issue of why some people die and some people survive. And they noticed that everything being equal, on 14th day, those who had neutralizing antibodies, they survived. And those who did not have neutralizing antibodies by 14th day, they would then die. So it was a dynamic response of neutralizing antibodies which determined whether a person survived or a person died. Subsequently, we've been looking at our own staff member. I have a set of 45 persons who have either had vaccination and then infection, or had only infection and no vaccination. And we've done a number of tests on them, whether starting from S1, S2, then trimeric, then neutralizing. And in a subset, we had tried to do even the T cells by using 𝐿-gens. That 𝐿-gen one did not give us clear-cut idea, so I'm not able to comment on the T cell response. But on the antibodies, I agree with Dr. Arora that those who had taken only vaccination, their immune response was less than if a person had vaccination and then got infected with Delta, or had infection in 2020 and then in 21 took vaccination. So a combination of vaccination and natural infection had higher titer than only 2 doses of vaccination. Those who have had infection in 2020, 1 dose alone would give you high titers. So maybe a second dose in those, maybe a too many one. And of course, there were a few of them, and I am one of them, who did not produce any neutralizing antibodies. And so I remember discussing once with Dr. 𝐾𝐀 where we did a series of webinars, and this was before the monoclonal antibodies became available. And as you know, he contracted the infection and he expired. This was before monoclonal antibodies became available. And now it is clear that those who do not produce antibodies would benefit by getting a dose of monoclonal antibodies within 72 hours of testing positive. So I am a strong proponent of finding out neutralizing antibodies so as to guide us that whether even after doses, 2 doses or 3 doses, if we do not produce neutralizing antibodies, then we remain susceptible to infection and to death if by 14th day our body does not produce antibodies. And we would gain by having access to either human monoclonals or even equine monoclonals, which Kasoli has produced. But that must be made available. It should not be only lying in regulators, authorities, or somebody or the other deciding whether a dose would be required or not. Many deaths would have occurred before that final decision is taken. And in these kind of pandemics, you have to take decisions preemptively rather than after everything becomes clear that yes, that would have benefited.
I think that is, the golden words that you've said today, among all are the fact that in a pandemic, you'd rather err on the side of over caution than being very, very cautious about taking every decision. And I think data is the driver, and all of us you need to share data at a lot more. Our focuses are on daily diagnostics and helping people on a daily basis, but I think having data of collective data on this kind of thing. Now, for example, there were papers that came out now, two papers that I remembered when both of you spoke. One was that of people with A gamma globulinemia who could not produce B cell response at all, also being able to get rid of the infection. So essentially there was some other cell that had its play in the whole, but of course they were speaking about infection. That was a paper from America that was discussed in detail in the American Society of Microbiology podcast. The second is that of our own understanding in terms of the antibody response that we're seeing, and with transplant patients, like Dr. Arora alluded to in his when he was discussing on transplant patients requiring probably a third dose, not a booster, and it's not as part of this 6 months later. So, or maybe like a person like Dr. Ashok was talking about himself not developing antibodies, would a third dose really benefit them? So I think what we need to really have is data, and we need to have a very, very open mind towards looking at data from different sources. There is some reason why the Caucasian population and the way they react to this virus and the vaccine is very different from what we're seeing from India. So unless we have data that's local, I think we stand to lose a little bit by only depending on data from abroad. What do you think, Dr. Arora?
Absolutely, I think it's the more data is shared. I think Professor spoke about this in the beginning, that the more data we share, and especially with the vaccine manufacturers, I think that is critical according to me. I think the more data that we share, I think building all labs that are doing testing, even if we were to build a central repository and try and collate data that we have from each other, between Pathkind and us, we would have done millions of tests so far. Now, there's so much of idle data that is sitting there. All that can be unearthed and can be shared with authorities to take, as you said, more agile decision making can be facilitated because of that. Absolutely, I think data is critical in making right decisions today.
Dr. Rattan, do you think the ICMR, because all of us are entering all the data into the tab with vaccination status and the fact whether they're testing positive or negative, do you think, the ICMR could help us, understand that data better? Because it's a huge amount of data from across the country, like Dr. Arora also spoke about. We are entering hundreds and hundreds and hundreds of results inside with data on the location of the patient, the transport of the patient, the vaccination status of the patient, the current comorbidities. Do you think we can do more about it at a more robust pace? What would you think?
I guess if they were analyzing and sharing data, that would have been useful, because then that would have reinforced the efforts that go into entering the data has been useful, though I haven't seen any evidence that it's been analyzed and used for decision making.
Right. There are some really interesting questions on the chat box, and let me go to that because we're almost nearing the close of today's really interesting discussion. I mean, I have so many more questions that I'd planned out for the two of you, but it's been riveting as a discussion from both of you. So I'll ask the first question, and either of you can take that. The first question is, do we have evidence of any reports that neutralizing antibodies, whether by infection or by vaccination, may not be effective against the new variant Omicron?
It's too early, I think.
Dr. Arora, your thoughts?
I think it's too early. I mean, initial data suggests that I think vaccinations will have a protective effect, because if the severity of the disease is blunted, I think vaccinations will have some impact of protection. So I think it's still too early, but I think vaccinations will definitely have a beneficial impact.
Yes. And I think everything is not falling into place, in the sense that there was a paper, there was news item from Japan, which said that they also had a highly mutated strain, and that has now fallen off. So that,
Right, right,
and we were, I remember sharing it in the group and saying that maybe that is how SARS, the original SARS in 2003, also
actually,
disappeared,
yes.
because it kept on mutating. Now, today morning, I was listening to a podcast where they were trying to say how this Omicron has suddenly appeared with 50 odd mutations, 32 mutations in the spike protein itself. And normally, by looking at the different acquisition of mutations in the spike protein, you can trace out its ancestors. But they noticed that this Omicron's predecessor could be traced to the mid 2020, and thereafter there's been no accumulation of mutations. And their hypothesis at this moment is that all these mutations has accumulated in the body of one person who was immunocompromised, and so not able to get rid of the virus. As a consequence, the virus continued to survive and mutate in the person, maybe an HIV positive patient, and then only when it had accumulated sufficient amount of mutations that it came out and spread.
Right.
And that might be the reason why you don't see uh, the sequential acquisition of more and more mutations in Omicron, and suddenly you find 50 mutations staring at. But if it is not neutralized, see, if it did not have affinity for the ACE2 receptor, it will not cause infection.
Mhm.
And we all agree that it is highly infectious.
Right, right.
But if it is not being neutralized, then it would have caused severe infection. And at this moment, though only 10 days have passed since it was first reported, there's been no flurry of deaths or hospitalization. So it
Right.
appears to be a mild infection. So it's not adding up, but I guess we will live to learn.
True, true. Very well said. Two questions that are related to, the vaccine efficacy and the new variant, both of which we can take together. One is how effective or ineffective may be the current vaccine, which you already answered now and said we are waiting for more data to come. As of now, we are not sure about how that is going to, shape up. The second important question is, you were going to tell us something about the chances of emergence of mutants that are not amenable to current vaccines in the future. So we're talking about new variants in the future coming up, which may not be, amenable to vaccines.
I guess, that coronavirus can be controlled by vaccine is clear. Now, if it is not amenable to the Wuhan vaccine, then you need to use the Delta or the Omicron as the booster.
Right.
If you use
right.
Omicron as the booster, then it will be effective.
Right. So interestingly, you brought this up, that I had as part of my questions, which I wanted to talk to you. There are two more questions here, but I'll take the liberty of putting my question before that. What are your thoughts on mixing up of vaccines? Because they're all of different.
Desirable. I think whether by purpose or by mistake, wherever the vaccines have been mixed, you've got better immune response.
Right.
So I think it is desirable, because it's also there, since you're getting different looks at the same antigen, the response is better.
Much better. Okay, that's very interesting. What about you, Dr. Arora? You had some thoughts
So
to
I
share?
think the simple answer is yes. In fact, we had family and friends who were traveling to Dubai and said that, we have access to Pfizer in Dubai. Should we take it? So I said, simple answer is yes, but the only thing is that it's not going to be part of the vaccine protocol, and that's why perhaps you should wait. So I guess the simple answer is yes, as long as I think the government protocol allows it to be recognized officially, so that it actually facilitates travel or whatever other, facilitations that need to happen because of taking the vaccine. So whatever safety it, because if you take it unofficially, it might give you the benefit, but it's not going to be, officially allowed for you to show that. So we are still hoping that the government will come back, at least allow a third dose to be given to healthcare workers, to senior citizens, to immunocompromised people. I think people who have taken the vaccine almost a year ago or 11 months ago, I think there is justification in trying to give them at least a third dose.
Right, right. Very interesting, though. The next question is on mutations in the spike and change in the binding of the virus. So that affecting the infectivity, and the transmission. How come there is these drastic changes that come about, with variants of concern and variants of, interest?
So I think, mutations happen on both sides of the spectrum. There are some mutations that, make the virus less infective. Those obviously don't come to attention. So we don't know how many mutations there are. Obviously, the ones which are of interest or of concern is the ones which people know of. But there are many mutations that make the virus actually less infective or less potent. So I think we just talk about one end of the spectrum. There is the other end of the spectrum as well, which is perhaps not spoken about or not known. So mutations are on both sides, I think, and it's not just only to make them more infective.
Right, right. What about Dr. Rattan? Do you have some thoughts to add on that?
Yeah, I think as we were hoping that there'll be mutations, and that way it will lose interest or it will lose affinity for ACE2 receptors of humans, and it will shut off itself. So the pandemic will end.
Nice. We all hope that that is the way forward for all of us. Of course, Zydus Cadila is coming up with the vaccine for the children, and there is also the Covaxin that has done its trials with the vaccine for children. Would you like to add some thoughts on like the opening of schools, because there's no longer sense in all of us staying cooped up at home? Yes, initially we needed the lockdown because we needed to gather our resources and actually get to testing and get to knowing the disease and its process well. But now that we are about a year and a half or almost close to 2 years through this pandemic, what would you want to say? Because what we realize is that though we put up posters everywhere, though we keep talking about masks, when I'm walking on my rounds, I see more people pull up their masks than when when I'm going to the ICUs, and then they'll be like, "Illa ma'am, ippoda edutho. I just took it out right now. I just went to have a drink of water. We just went to have a break, so I took my mask out." So getting people to mask seems like it's probably fatigue over the 2 years that we've been asking people to mask. So, and vaccines, of course, there's mixed responses on that as well. So for children, how do we go about it?
So maybe I can start. I know feedback from some young mothers who have children who, are potentially able to go to school. I think all mothers and children want to get back to school. But where the concern comes is that if the school makes it mandatory for the child to take a vaccine before sending the children to school, and the mothers have a concern on the long-term safety or efficacy, maybe for adults, it's still okay, but for children, I guess the mothers, I've heard concerns from quite a few mothers who have children who are 5 or 10 years old, and they say there is not enough data, to show efficacy or safety in children. I don't know if it, if the school makes it mandatory, what will I do in that situation? So I think there's a little bit of a concern, for at least young children, to take the vaccine. I don't know what has Sir heard on that.
I think the parents would not allow the children to go to school without vaccination, because wherever the school has opened, then whether it's in America or in UK or wherever, they have opened the school, the children acquire infection in a herd, and then they have to close again. So I think the wisest would be to vaccinate the children, and maybe if they use an innocuous vaccine like Covaxin, which all said and done is a dead antigen only. And if that is used, then I don't think anybody should have any fear that it will have side effects which will have far-reaching consequences. The others we do not know. The messenger RNA we don't know completely. The DNA we don't know completely. The vector we do not know. And maybe you would like to err on the side of caution. So maybe Covaxin is the answer to give to children. Give them at least one dose so that they are primed. And as it is, we say that they have very mild infection wherever they've had. I know in my own family, my wife, who was already vaccinated, she got infected. My daughter, who stays with us, she had had one vaccination and still got infected. And my grandson, who's all of 10 years old, he also got infected, and he had the mildest. Maybe one day he had all of them RT-PCR positive. So the children are having mild infection. So maybe one dose of Covaxin would prime them, and then they can go back to school. And unless, of course, Omicron gives them natural vaccinations. And
Right.
So another interesting question is, could there be a possibility of antibody-dependent enhancement playing a role in the rapid spread of the new variant?
I don't know how to address that issue.
No, nor do I. I haven't read up much about that, but maybe we can come back to the author of that question with a little more data in future. And then there is there any data on malnourishment or severe anemia, on this viral severity and the mortality, like, with the different mutants that are there, or rather variants which are there, have they, shown a worsening of symptoms because of these, comorbidities?
No, not that we have noticed anything.
And there's no direct data. I guess it's just indirect that I guess they will have an impact on your immunity,
Right.
indirectly, and then that will have an impact on your response.
Right.
So I don't think there's any direct data. At least I'm not aware of.
Right. So in fact, I would, add on here that this data we could do from India very well because of the number of people with anemia and, malnourishment being quite common. And the fact that, there is an ICMR app, which we are actually filling data in. I think we could contribute to that if only we could share data, like was said before. Dr. Rattan, your thoughts, please.
Yeah, I was just thinking that, see, if we talk about immunity, the death occurs because of hyperimmune response. It's not the virus which is killing; it is the hyperimmune. So if our anemic and famished persons were more immune, we would have seen more deaths. I don't think it's happened like that. So,
right.
But maybe we need to have more evidence, then we can decide.
Right. So I think, we've had a really nice session. A lot of people found the talk extremely effective and interesting and informative. And I think I thoroughly enjoyed. I didn't realize that over an hour had passed through since we started our discussion. Indeed, it was a pleasure to interact with both Dr. Ashok Rattan and Dr. Sanjay Arora. Thank you so much for, being so patient and helping me out with this discussion. I'd also like to, place again on record our thanks as part of this panel. I'd place my thanks on the table to Cipla Diagnostics for organizing such a beautiful session. And I'm now going to hand it over to Dr. Rohit for the closing remarks. Thank you so much.
Yeah, thank you
Dr.
very
Anusha.
much, Madam. From behalf of Cipla, I'd like to thank Dr. Anusha, Rohit, Madam, for the excellent moderation and very smooth moderation of the session, and Dr. Sanjay Arora and Professor Dr. Ashok Rattan for very extensive and detailed information regarding all the diagnostic aspects and the variants of the COVID-19. And lastly, I would like to thank all the attending doctors for sparing their time and attending the session. Thank you all.
Thank you. Thank you.